Antenatal CTG monitoring and documentation. The learning outcome of this module is to be able to describe when antenatal fetal monitoring is used, to analyze the components of computerized CTG monitoring, including Dawes-Redman criteria, to understand and demonstrate safe practice with antenatal and computerized CTG interpretation, to complete accurate CTG documentation in line with hospital guidelines, and to understand personal limitations and when to escalate care. The physiology of antenatal CTG involves components of an antenatal CTG, which is when the fetus is not under stress. The features involved in an antenatal CTG are the same as in an intrapartum CTG, that involves baseline fetal heart rate, baseline variability in the fetal heart rate, accelerations and decelerations. Looking at each component in detail, the baseline fetal heart rate is regulated by the autonomic nervous system. Sympathetic nervous system helps to regulate the fight or flight response, that is, the response to stress, and increases the heart rate. The parasympathetic nervous system will help to downregulate this heart rate and tends to develop later in gestation. Consequently, a preterm fetus has a higher baseline heart rate. However, in conditions such as maternal pyrexia, stress response related to hypoxia can also lead to increased sympathetic response and hence increase in the fetal heart rate. Baseline variability is dependent on the maturity of parasympathetic nervous system. The parasympathetic nervous system will help to downregulate. The baseline variability is dependent on the maturity of parasympathetic system. The parasympathetic system is therefore responsible for the sleep and wake cycle and generates this variability in the CTG. The reassuring pattern of alternating reduced variability reflects the different behavioral states called cycling. Reduced variability can be associated with medications such as antenatal brain injury, hypoxia, leading to anaerobic metabolism and acidosis, which affects the central nervous system. This is suggestive of decompensation in a fetus and hence a reduced variability in the absence of cycling pattern, and accelerations can be suggestive of decompensation and needs to be acted upon. Accelerations are caused by fetal somatic activity. This transient skeletal muscle activity increases with because of fetal activity, and this will increase in the heart rate. A fetus who is compromised will try and reduce the skeletal muscle activity to conserve energy. Presence of accelerations is reassuring in an antenatal CTG. Absence of accelerations needs to be looked at in line with the assessment, with the overall assessment, including the assessment of fetal movements. Decelerations are usually suggestive of hypoxic insult and should not be present in an antenatal CTG. Presence of decelerations could reflect an hypoxic insult, poor placental perfusion, maternal complications, or acute events such as abruption and cord prolapse, and hence needs to be assessed in the overall in this situation picture. So in order to understand the antenatal CTG, it is also important to understand the fetal adaptation to chronic hypoxia, because it is this that will be reflected in the changes on an antenatal CTG. In fetal growth restriction, the fetus tries to prioritize the fetal blood to the blood flow to fetal brain, heart, and adrenals, and in the initial compensatory phase, the fetal abdominal circumference is reduced on ultrasound scan. Fetus also conserves energy by reduced fetal movements. This is what we see on growth charts on ultrasound scan. The brain blood flow increases and there may be reduced LICA volume as fetal renal perfusion reduces. Subsequently, there is increased in-placental resistance, and this is reflected in raised umbilical artery pulsatility index measured on Doppler scan of umbilical arteries. At this stage, as a part of compensatory response by the sympathetic system, there may be an increase in fetal heart rate on CTG. As the fetus tries to decompensate, there is reduced variability and hypoxia, which can result on decelerations on the CTG. Also, in chronic hypoxia with acidosis and decompensation, there can be a reduction in baseline heart rate due to myocardial depression. The reduced variability and absence of cycling can be identified better by a computerized CTG. So the indications of antenatal CTG, both inpatient or outpatient setting, include monitoring for fetal well-being in maternal problems such as preeclampsia, preterm rupture of membranes, hypertension, maternal medical problems with fetal concerns, vaginal bleeding, abdominal pain, trauma, and fetal indications such as fetal growth restriction, reduced fetal movements. So, antenatal fetal monitoring can be performed in a conventional way or using a computerized antenatal electronic fetal monitoring. Prior to commencing continuous electronic fetal monitoring, simultaneously palpate maternal pulse while auscultating the fetal heart to differentiate between the two. Follow minimum standards of documentation. An abdominal palpation should be performed to identify the presentation and an optimal area of auscultation. Fetal heart rate must be auscultated with a Pinard stethoscope or a sonic for at least 1 minute before commencing the CTG. We must ensure that the date and the time on the CTG is correctly set. The monitor is set up to run at 1 centimeter per minute. Position the toco and the ultrasound transducer. Connect the fetal event marker and show the mother how to use it. Turn the analysis on and ensure gestation is inserted correctly. So, what are the advantages of computerized CTG over a conventional CTG? It is an objective analysis of fetal heart rate trace. It eliminates the problems associated with highly subjective interpretation based on visual interpretation. There are no national standards in antenatal CTG, and hence having a computerized CTG which is objective, reproducible and consistent helps. It also considers several different aspects of fetal health. It was developed by Professor Chris Redman and fetal physiologist Jeffrey Dawes in order to address the need for reliable, reproducible, and accurate measurements of antepartum CTG patterns to aid interpretation. This video link will describes about the origin of Dawes-Redman criteria. So, what are the indications for using Dawes-Redman criteria or computerized CTG? We've already described the indications of antenatal CTG, especially in situations such as high-risk maternal or fetal condition that may have a negative impact on fetal well-being. Dawes-Redman criteria is very helpful. It is also very helpful in reduced fetal movements and fetal growth restriction because it can identify a chronically hypoxic fetus. It is useful in twins with discordant growth and in preeclampsia. When do we use Dawes-Redman criteria in relation to gestation? We use it about 26 weeks. we would interpret it with caution between 26 and 28 weeks because of the differences in fetal heart variability and fetal behavioral patterns at this gestation. It is not to be used in labor if any woman has got contractions, not after use of propes, and not in latent phase. So this table summarizes the use of an antenatal CTG. To begin with, we would confirm the rationale for CTG. If a CTG is indicated, we then identify if the pregnancy is beyond 26 weeks, and if it is, then a computerized CTG or a conventional CTG would be used. We have to make sure that we rule out any presence of uterine contractions, latent phase of labor, or induction of labor. In these situations, Dawes-Redman criteria is not valid. So once we've confirmed the indication of a computerized CTG, we commence the Dawes-Redman criteria, Dawes-Redman recording. We start a CTG in line with the process that has been described before, and we input the gestational age and we start the analysis. Once the analysis is started, there are 3 pathways that it will follow, and these will be described in the subsequent slides. Either the criteria is met or the criteria is not met, but it's less than 60 minutes, and the criteria not met after 60 minutes. Remember, ensure the Dawes-Redman criteria is switched on as antenatal analysis. So, in the next few slides, we will describe how computerized CTG works. It works in a 2-stage process. Firstly, it derives a dataset similar to traditional clinical observation process and then applies the Dawes-Redman criteria to this dataset. It uses the computerized numerical analysis of the CTG, which is derived from world's largest database linked to outcomes. The dataset derived by computerized analysis include the following parameters. Signal loss, so the percentage of trace length for which there is no fetal heart rate data is recorded as percentage of signal loss. This ensures that there is good quality signal in the CTG that is being interpreted. Secondly, movements. It is similar to the traditional technique where movements are perceived by the patient and the woman will press the event recorder. It is not used in monitoring twin pregnancies because it cannot differentiate movements between each twin, and it will record the movements common to either of the twin. Number 3, basal heart rate. So this is different from baseline heart rate and is calculated by the software. So it may deviate significantly from the visual assessment of baseline heart rate, particularly in a CTG which has got periods of prolonged high or low rates. Number 4 is contractions. These are recorded as per the traditional technique. Number 5 is accelerations. They are the same as conventional CTG definition but are quantified and presented in 2 groups. One is amplitude of greater than 10 beats per minute and second is amplitude of greater than 15 beats per minute. Number 6 is decelerations. Again, the way decelerations are recorded and reported is different to the traditional CTG. The number of decelerations is defined as per the conventional CTG, but additionally, they are quantified in terms of greater than 20 lost beats, a measure of depth and duration of deceleration. Now, the most important feature of computerized CTG is the reactivity of fetal heartbeat. Fetal heartbeat variation has been shown to be the most useful computerized CTG indicator of fetal well-being in antepartum. 2 normal sources of fetal heart rate variation are gestational maturity and episodic changes in fetal behavioral states after 28 weeks gestation. The system was designed to take into account the episodic changes in fetal heart rate and fetal movements characteristic of sleep states. Even in the absence of acceleration in normal fetus, there is at least one episode of high fetal heart variation from 28 weeks onwards. This is reported as long-term variation and short-term variation in the computerized CTG. Short-term variation. So this is a significant benefit of short-term variation is that it is independent of baseline heart rate. The mean as short-term variation increases as gestational age advances. Short-term variation cannot be assessed visually from looking at the trace, and it is not the same as variability on a CTG. There isn't enough detail in the printed trace to be able to assess the Sdv. It must not be used in isolation as an indicator of fetal condition. It is calculated by the Computerized Ctg software. You can have a normal Sdv with a severely compromised fetus, and hence it should not be used in isolation. It is only significant as a part of a full 60-minute analysis. Overall, the thresholds of abnormal short-term variation or Sdv are as below. If it is less than 4 meters per second, it is low. If it is less than 3, it is abnormal, and less than 2 is highly abnormal. This is an important feature that enables assessment of fetal growth restriction and helps to identify a fetus that is compromised. So, summarizing, this is a trace that describes and demonstrates how Redman CTG appears on the printout. As you can see, the 7 parameters that I have already described have been narrated on the side: signal loss, fetal movements per hour, basal heart rate, contraction peaks, acceleration, deceleration, high episodes of variation, low episodes of variation, and short-term variation. And at the bottom, the trace says Redman criteria met at 10 minutes. Analysis is not valid in labor, and this is not a diagnosis. So, what do we do when criteria are met? The practitioner commencing the CTG must return within 10 minutes to ensure the quality of the CTG, to assess visually whether the CTG is normal. The CTG can meet Redman criteria in as little as 10 minutes. If it meets Redman criteria, this is a normal result. Unless there are any other clinical concerns, the analysis can be stopped and a report of the analysis is printed. This is the recommendation from the Huntley machines who have the computerized CTG software. The practitioner who stops the CTG must sign the CTG at the end of the printout, including a visual assessment to confirm the CTG is normal and document the result in the notes. It is important to perform a holistic assessment of the case. Think about the reason for the CTG, the situation, the background information, and hence if a CTG is normal and there are no other concerns in this situation, it can be taken off in 10 minutes and no further action is needed. In relation to a normal CTG or a conventional CTG, in general, we would continue the CTG for at least 20 minutes before taking the CTG off if the CTG is normal. In terms of how long we leave the CTG on. If the CTG is normal but Redman criteria are not met, then we continue it for 60 minutes. If after 60 minutes Redman criteria are still not met, then we need an immediate medical review, and I will come to the pathway where it says criteria not met. If Redman criteria are not met and the CTG has abnormal features even from the beginning, immediate medical review by a consultant or senior registrar must be sought for. It is important that while immediate medical help is reviewed, it has to be used in an S-bar handover and recorded accurately in the notes. When the criteria are not met at 60 minutes, the computer will end the analysis and print the results on the trace. The reasons why the criteria were not met are highlighted as coded numbers. This should be considered a pathological outcome. An appropriate case review and action must be taken. This review should be undertaken by a senior obstetrician, a senior registrar, or a consultant to plan further management. Do not act on the basis of CTG alone because this is to aid pregnancy management and is not a diagnostic tool. There are situations, for example, where either the gestational age is between 26-28 weeks or there is a lot of signal loss where the criteria may not be met. However, there are fetal movements and it is clearly not a pathological CTG in that context. However, this varies depending on the situation. Sometimes the criteria may be met earlier and then subsequently are not met at 60 minutes. And in that situation, the computerized CTG criteria should be reviewed again and medical review should be undertaken. So, the limitations of a computerized CTG. Sdv is not the only parameter of interest. Antepartum CTG only indicates the current fetal state. It is not a predictive or a screening test. Instances of fetal death occurring within short time of normal fetal CTG have been reported. These are likely to be in the category of unexplained stillbirths. It cannot predict abruption or infection. So the key learning points are: use your clinical assessment skills. Redman analysis cannot predict acute events. Do not act on the basis of CTG analysis alone. This is to aid pregnancy management, is not a diagnostic tool. Occasionally, it might not be possible to get computerized CTG in women with very raised BMI or polyhydramnios, and urgent medical review is warranted. This tool is only used for antenatal women over 26 weeks gestation. Do not use in labor, latent phase, or during the process of induction of labor. It can be done on antenatal inpatients or outpatients, but not intrapartum. All Huntley CTG machines can perform Redman CTG analysis. If criteria is not met or the CTG looks abnormal, immediate senior obstetric medical review and an S-bar analysis is essential, and this should be with a consultant or a senior registrar. Documentation-wise, all the documentation on CTG should be recorded by registered midwives on the CTG itself and patient medical notes. At the start of CTG recording, ensure that the CTG is labeled with name, hospital number, and reason for the CTG. The date and time is correct. Maternal pulse is recorded at the beginning of the CTG. Fetal gestation is recorded. Practitioner to sign, date, and print. And remember to ensure that Redman criteria is switched on depending on the machine that is used. There are some links to some resources here, and also this refers to our recent updated antenatal fetal monitoring guidelines.
Welcome to the NUH Maternity Intrapartum CTG Interpretation and Communication Learning Package. This package is designed to be used together with the K2 package and does not duplicate or replace the learning within K2. The specific elements covered in in this session are Intrapartum CTG documentation, CTG classification according to the NICE guidance, the importance of holistic assessment and situational awareness when considering CTGs, and to raise our awareness of the human factors that can affect us when and how we classify and act on CTGs. We'll cover using SBAR for effective communication and the PACE tool for escalating concerns. We'll also cover supporting professional challenge. The learning objectives are for this session that we'll recap on the NICE guidance for intrapartum CTG interpretation. We'll outline the actions and documentation requirements when you're commencing CTG, and we'll discuss the effective use of the Philips CTG machines which are in use at NUH. We'll also introduce the human factors and how they can impact on CTG interpretation and care, and we'll introduce the use of the PACE tool and professional challenge so that you feel empowered to ensure that any concerns about CTG are listened to and acted on appropriately. Being able to correctly interpret, classify and appropriately act on the CTG is essential to our practice as midwives and obstetricians. The interpretation of the CTG has to be done in the context of a holistic assessment of the woman and her wishes. This should not only form part of our clinical management plan, but also our documentation around CTGs. Recognising how other factors might influence us when we classify and interpret a CTG is really important, because it not only influences our own actions, but that of our colleagues. Attention to all of these elements is really important for optimising the safety and outcomes for our women and babies in our care. Many of you will have already seen the Time Escalation Decision series of videos produced by the University Hospitals of Leicester team. If you haven't seen this, please take a moment to copy the link into the browser and take the time to watch this video. It really outlines the importance of not only how we view a CTG ourselves, but how we communicate it with our colleagues and with the women in our care, and how that can impact on the overall outcome. With regard to the documentation of the CTG itself, all of the documentation should be recorded on the CTG should be recorded by the registered midwife, both on the CTG itself and in the patient's medical notes. At the start of the CTG recording, you must ensure that the CTG is labelled with the name, hospital number and the reason for the CTG. You must check the date and time is correct and write the date of time that the CTG was commenced. The maternal pulse must be recorded at the beginning, along with the gestation and the signature, date and printed name of the practitioner. When you start a CTG, make sure that you've labelled it as per the documentation standards outlined in the previous slide. Add the information that you've written to the CTG into the mother's clinical notes. It's really important that when you start the CTG that you check that the date and time on the machine is correct and that this matches the time on the wall clock in the labour room. You can alter the time on the machine in the settings if it's incorrect. It's also important to check that the paper speed is set up at 1 centimetre a minute. Again, you can alter this if it's not correct before you start the recording. Make sure that you auscultate the fetal heart using a pinad or a handheld Doppler rather than the CTG transducer before you start your trace. Again, make sure that you document that you've done this in the clinical notes. Documenting the mother's pulse, the fetal gestation and the reason you're doing the CTG adds context to the CTG interpretation and should always be done. This is a reminder of the NICE classification of CTG features, which can be reassuring, non-reassuring, or abnormal. Please remember that you don't have to remember these. They're available on the NICE guidance, on our own fetal monitoring guideline, and they should be available as posters either on the wall or attached to the CTG machine in all of our labour rooms. The expectation is that staff will review this table when they are classifying CTG features during labour. You can use this table and the categorization table that follows when you're doing your assessment. Once you have classified the individual CTG characteristics, you then need to categorize the CTG as normal, suspicious, or pathological. You must categorize the CTG each time you review it and document this in the record. Something that you must always remember when you use the Philips machine is that if you're using the abdominal monitor, the machine will read FH1. If during the mother's labour you switch to using a fetal scalp electrode, and you put the FSE on and start, the machine will say FH2. It's really important to be aware of this, whether you're an obstetric doctor or a midwife, because if this happens, it will add 20 beats per minute to the paper printout, so there'll be a discrepancy between the reading of the fetal heart rate on the machine and that on the paper printout for CTG. It's important that this is resolved as soon as you become aware of it by breaking the red connection between the TOCO and the FSE, reconnecting them, and then the machine should now say FHR1, which will indicate that the correct heart rate is recording. Unfortunately, there is not a way to automatically prevent this from happening, so it's important that staff are all aware. During labour, any events that might affect the fetal heart tracing should be noted on the CTG tracing, timed, dated and signed. This could include vaginal examination or epidural, for example. Any member of staff who is asked to provide an opinion on the CTG should draw a line and sign the trace at the point at which they're reviewing it. They should also record their findings, including characterising and classifying the CTG, on a sticker in the maternal case notes, along with the date, time, their signature, and if they haven't signed the signature log, a printed name and their role. They should also make sure that they've communicated the reason that they've reviewed the CTG and their findings with the woman and documented in the notes that they've done so. The attending midwife should perform a systematic assessment of the features of the CTG and the overall categorisation at least once each hour, and this should be documented by using a sticker in the intrapartum record. Additionally, a fresh eyes review should be undertaken every 2 hours. This should usually be performed by the named buddy midwife. However, if the buddy is unavailable, another midwife or doctor can provide the fresh eyes review. Following birth, when the CTG is discontinued, the midwife should sign and note the date, time and mode of birth on the CTG trace. Where a CTG is necessary to monitor fetal well-being, it must be of good quality. If there's loss of contact, the CTG can't be interpreted correctly. If it's not possible to obtain a good quality CTG, the following measures should be considered: changing the maternal position, using ultrasound to locate the fetal heart and position for optimal transducer placement, or the use of a fetal scalp electrode. Even if you think the CTG loss of contact will only be short-lived, for example when an epidural has been sited, it's really important that these measures are considered and that every effort is made to resolve any loss of contact. For example, if you're unable to monitor while an epidural is being sited, then you should pause the siting, apply an FSE, and then start again. If despite these measures you're still unable to obtain a good quality CTG, this should be escalated promptly to the coordinating midwife or one of the doctors. These slides show the fetal scalp electrodes that are currently in use at NUH. In this next section, we'll consider human factors, communication, escalation and professional challenge. These are so important to our work and can have as much of an impact on patient safety as our knowledge of CTG classification. Although for the purposes of this teaching session we have a CTG focus for these scenarios, these can be applied to all areas of our work. This video, produced by the Each Baby Counts team, demonstrates human factors at play on the labour suite and how we can minimise the impact of these on patient safety. It really emphasises the importance of maintaining situational awareness both for individual women that we're caring for and the maternity unit as a whole. Situational awareness is multifactorial. The first component of this is self-monitoring. There are lots of factors that can influence our ability to do our jobs effectively. Tiredness, stress and hunger are among the factors that can make us work less effectively and can affect our decision making. Using the I Am Safe checklist can help you focus on how you're feeling and whether there is anything that you need to address. Even a few moments break to pause, gather your thoughts, eat, or go to the toilet can improve our ability to do our jobs. The Each Baby Counts video shows the importance of situational awareness in maintaining safety on the labour suite. Every member of the maternity team can do this, both by monitoring the behaviour, by self-monitoring, as discussed in the previous slide, and maintaining an awareness of actions and behaviours around us. Any member of the team can speak up if they see something that they think needs addressing. Cross-monitoring involves being aware of our colleagues and the tasks they are performing as well as our own. It means that we can all keep situational awareness and we can watch each other's back and offer help and reassurance where it's needed. The way we communicate to each other within the maternity team can have a huge impact on the safety of women and their babies. The way information is given will influence how it's received by a colleague and in turn their actions. When we communicate about clinical information, this should be in the SBAR format. Using SBAR conveys all of the essential information to your colleague and means that you're more likely to get the response you need in a timely manner. Other phrases are open to misinterpretation and may lead to delays or errors in management of the situation. Phrases such as "the CTG is sleepy," "the trace is dipping," "I don't like the CTG," or "I'm a bit worried" don't necessarily convey what's going on. If in reality you had a pathological CTG which needed urgent medical attention, phrasing it in this way would not convey that urgency. In particular, asking for a fresh eyes review when you have a CTG that is suspicious or pathological will not convey to your colleague the urgency or what you're asking of them. The SBAR format lets us organise our communication and convey this clearly to our colleagues. We need to describe the situation, background, assessment and recommendation. This slide gives an example of how you can use SBAR to discuss concerns about a CTG. For example, the situation is the CTG in room 10 is pathological. The background is the woman is para 1 with a previous forceps birth. She is in established labour, she has no pre-existing risk factors and she's been midwifery-led care during her pregnancy. The assessment is that her mu score is 0 and the lycra is clear. She was 6 centimetres dilated on vaginal examination at 8 o'clock, having progressed 3 centimetres since her previous cervical assessment. My recommendation is that she should have an urgent obstetric assessment with a view to fetal blood sampling or delivery. It's also okay to use SBAR when you feel uncertain how to categorise the CTG. For example, the situation is that I don't know how to interpret what I'm seeing on the CTG. The background is the woman is para 0, 37 weeks and 2 days and in spontaneous labour. She's had growth scans during the pregnancy due to smoking. The most recent was at 36 weeks and was normal. The assessment is that she was admitted 4 hours ago and was 5 centimetres dilated with intact membranes. Her mu score is normal. The midwife asked me to review the CTG and she thinks it's sinusoidal. My recommendation is that you should come and review her as I need a second opinion. What happens if you escalate a concern and you don't get the response from your colleague that you're expecting? Whatever your role, you do have an equal voice and responsibility for the safety of women and babies in our care. As we saw in the Each Baby Counts video, anyone can become task-focused and distracted. If you escalate something and you don't feel happy with the response that you get, we want you to feel supported and that you have the tools you need to continue the professional conversations until you feel happy with the response. At NUH Maternity, we want every member of our team, whether you're the most junior or the most senior, to be able to address any concerns with a colleague. We know that sometimes when you're the more junior member of the team, it's easy to assume that the senior person is right or can feel difficult to challenge a decision that they've made. However, as part of the whole maternity team, we need to be able to communicate to understand each other's decisions and be in a position that every member of the team understands the reason that actions are being taken. The next slide will outline how we can use the PACE tool to have these conversations. If you've applied this and you still feel unsatisfied with the actions or explanations of your colleague, then you can follow the clinical escalation path in the NUH Maternity Communication Guideline. The PACE tool frames how we can escalate our concerns. Firstly, probe. gain attention or raise the concern. Next, alert, repeat the concern, increase your volume. The next is challenge, formally state your concerns and challenge the individual's decision. And then emergency, get eye contact and potentially take over the task or escalate to someone else. An example of PACE in practice. Your probe would be your initial S-bar of the situation. Consider the CTG, the pathological CTG from the previous slide, that we used S-bar to communicate to our colleague. In this scenario, the midwife has used S-bar to communicate her recommendation that an urgent obstetric assessment is needed. However, if the registrar did not attend to perform the assessment, the next would be the alert. Did you hear me say that the CTG is pathological and needs urgent assessment? If the action is still not carried out, the next step would be the challenge. The CTG has late decelerations and reduced variability for over 30 minutes. It is pathological according to the NICE guidance. A fetal blood sampling or delivery should be recommended. Finally, emergency. I'm concerned about the safety of the baby. Please call your consultant colleague for a second opinion. If you don't do this, I will call them directly. If a consultant's made a decision that you don't feel happy with, you should still feel able to discuss this further with them and challenge if necessary. As outlined in the NUH communication guidance, the first step around this would be to have a discussion to ensure that you both understand the facts and the reasoning surrounding the decision. Ideally, have this discussion in a non-clinical area, away from the woman, and in private. It may be that after you've discussed the situation, you feel happy with the explanation and therefore don't feel the need to take any further action. However, if you're still unhappy, speak to the Labour Suite coordinator or Tier 3 doctor, who is the senior registrar. If they share your concerns, ask the consultant to explain their decision again, and if you remain dissatisfied, then ask the consultant to seek a second opinion from their colleague. If they decline to do so, then the coordinator, ward manager, senior registrar should inform the consultant who's declined to seek a second opinion. They will ask for this opinion from another consultant themselves. In working hours, the second opinion should ideally be from another consultant who is on site. Out of hours, this can be from the consultant who is on call at the other campus via switchboard. I hope that you found this presentation helpful. Remember, you do also have to complete your K2 training in addition to this package and assessment. You should now go on to complete the NUH Competency Assessment, which will test some of the concepts that we've discussed in this training video. Please remember that when you do the assessment, you can refer to the NICE classification and categorization tables. You don't have to try and remember them. Obstetric doctors can access some really useful communication skills tutorials on the RCOG website. The NUH weekly CTG meetings, alternating between a Thursday hosted by QMC and a Friday hosted by City, are open to all staff. It's a really useful way to support learning and is in the format of a case-based discussion. The meeting is open to all staff in maternity. We know that fetal monitoring can be complex and the Labour Suite is a challenging environment to work on. Don't forget there are sources of support that you can access if you wish to discuss any aspects covered in the tutorial today. Thank you for taking the time to complete this training.